Good afternoon, everybody. We're just letting everyone in to the room, the virtual room. Give it another minute or so. Thanks, Ethel. You have a fast finger there letting people in. All right. Okay, I think that we are in a good place to get started. Thank you very much, everyone who has come here this afternoon for the second combined health equity and translational social science theme and the Rangel social medicine grand rounds. It is a great pleasure and really exciting to have this particular guest speaker with us today as just our second combined seminar. So with that, I am going to turn it over to the wonderful Dr. Erica Bath to do the introduction of our special guest. Dr. Bath.
Thanks, Dr. Dicker. We are really grateful to have the indomitable Dr. Ayana Jordan today presenting on strengthening our communities by providing culturally informed treatment for substance use disorders. Dr. Jordan attended a historically Black university, Hampton, located in Virginia. And at Hampton, Dr. Jordan became interested in basic science, specifically virology, and worked in Helsinki, Finland as a researcher studying hantaviruses at the University of Helsinki. After college, continuing her love for basic science and virology, Dr. Jordan conducted HIV research at the National Institutes of Health. She contemplated combining her love for basic sciences with the clinical sciences due to her passion for human interaction. In 2003, Dr. Jordan left the NIH and began an MD PhD program at Albert Einstein College of Medicine of Yeshiva University in New York City. In medical school, Dr. Jordan became passionate about serving minoritized populations, specifically within psychiatry. She completed her general adult psychiatry residency at Yale University in 2015, where she served as program-wide chief. During residency, she became interested in treating patients with substance use disorders, given the intense stigma witnessed from other disciplines. As such, she completed specialized training in addiction psychiatry at Yale. As a fellow, Dr. Jordan obtained the American Psychiatric Association SAMHSA Substance Abuse Fellowship Award, which provided her resources to study ways to improve access to substance use treatments in the Black community. Dr. Jordan is currently an assistant professor at Yale, an attending physician at Connecticut Mental Health Center. She's committed to increasing access to addiction services within minority communities, both nationally and abroad. She has done research in Sierra Leone, West Africa, examining the links between mental health, substance use, and stigma. She has served as an expert witness discussing the current mental health system in Sierra Leone. Currently, she collaborates with physicians in Sierra Leone to develop a telepsychiatry program in rural districts of the country. Nationally, she's working on a project to provide computer-based cognitive behavioral therapy called CBT for CBT within the Black church, an evidence-based therapeutic modality shown to be effective in decreasing substance use. Dr. Jordan is interested in making connections with key stakeholders in the Black community to make this project a success. Most recently, Dr. Jordan was appointed the new director of the Yale Psychiatry Residency Global Mental Health Program. She is the proud recipient of various clinical and research awards that are too numerous to detail here. And she was recently inducted into the top 40 under 40 society by her undergraduate alma mater. Without further ado, take it away, Dr. Jordan.
Thank you so much, Dr. Bath. I am so excited to be here. Thank you all to the organizers for having me. Thank you to the attendings from Charles Drew, and also the attendings joining from UCLA, and everyone here. We are excited to talk about how can we, as medical health professionals, lay people, people who are interested in the liberation of minoritized people, think about providing culturally informed care. So I'm happy to talk about that today. I always start my talks with land acknowledgements, and I think it's really important to realize that the place where we do research and we give talks is really the land of the indigenous people. It's not our land, and we need to really think critically about how we can be good stewards of this land, right? And really think thoughtfully about what we do with these resources. So I am in California. I am the land of what we now call California, the land of the indigenous people, Gabrielino and Tongva tribes, who have stewarded this land throughout generations. And I thank them for their strength and resilience in protecting this land. I think it's important to recognize that land acknowledgements do not just exist in the past tense, right? Or the historical tense, but realizing that colonialism is a current ongoing process, and we need to be mindful of our present participation. And I think through that, because we cannot really liberate or strengthen communities unless we understand how colonialism has participated in the elimination of resources, and how can we restore those resources to the very communities. I also say, stop killing us. And as a Black woman who works with Black people and is really invested in the liberation of Black folks, I say this quite literally: stop killing us by gunning us down in the streets, knees in our necks, which we saw for George Floyd, just for being a teenager, which we saw recently for Ma'Khia Bryant, for having air freshener in the car, which we saw for Dante Wright. Stop killing us, right? Literally, but also stop killing us figuratively. And in my talk, what's quite relevant is through inequitable racist drug policies. And I'll talk a little bit about that, but I was most affected by the death of Breonna Taylor last year. There was a period of time that I would go on and I genuinely couldn't sleep because I would have nightmares in bed thinking through, trying to warn her, Breonna, they're coming in, they're going to kill you. Get up, get up, get out. So I want us to collectively understand that what is happening in our socio-political space right now affects the very people in which we serve, but also affects us. And if it's not affecting you, you need to figure out why not and be tuned in, because you can't care for people if you don't have a genuine love for the people. So I'd like to just stop. And I always say, I want us to be present in this space. And I'll talk about the liberated space that we've now entered in together. But can we honor the humanity of Black people in this country and just think about the lives lost from racist drug policies? Breonna Taylor, Danielle Prude, Walter Wallace, so many to name, but I'd like to just stop for 30 seconds to give honor to those lives. Thank you guys for that. All right, so UCLA and Drew, we are in a liberated space together. And I'd like to just quickly go over what that means, because a lot of people focus on a safe space, and I try not to use that language. I'll talk a little bit later in the talk when I'm saying how we have to be very deliberate about the language that we use when we're talking about people who use drugs. But in this liberated space, realizing that we might not agree with one another, you might not like what Dr. Jordan has to say, and that is okay, because often in the liberated space, we are able to show up and express ideas and push ourselves to think broader than how we entered into this space originally. And oftentimes within conflict, there lies growth. So let's grow together, let's think together, let's be innovative in this liberated space. You can show up any way you want as long as you are being authentic. You can keep your cameras on or keep them off. As long as you're tuned in this liberated space, that's all that I care about. I would encourage you to put your thoughts in the chat. If you think you're going to forget it, you can, listen, I was born in the Black church, raised in the Black church, so you can take yourself off mute and say Ashe, Amen, whatever you need to do to respond. But I don't say safe space because, as we've seen, the concept of safety is not available to all, not psychological safety or not even physical safety. So rather, let's be in a liberated space where we can learn together. I have no conflicts of interest to disclose. So 3 main objectives from my talk today, and I'm going to talk for about 45 minutes, and then I'm hoping that we can have discussion. But first, I want to go over the socio and political factors that contribute to the existence and propagation of opioid use and the Black community and the risks related to that. And then I'm going to switch and really focus on other substances that are commonly misused in Black communities, but are largely unrecognized in the mainstream media, and pose some theories on why that is. And then lastly, I'm going to talk about the work that we do in the Jordan Wellness Collaboration, some non-traditional modalities for treating people with substance use disorder. So really quickly, let's go over the current state of affairs. I don't want to spend too much time on this because the bottom line is it's abominable. People who use substances in this country are not well taken care of, and definitely Black populations have the worst outcomes. This has all been exacerbated by COVID-19, and I'll give you some data to underscore that. I think what is tragic, though, is even before the pandemic, I call it the Rona, came on the scene, that the state of addiction in Black communities was largely overlooked by regulatory agencies, including healthcare, academia, law enforcement, etc., until it really affected white communities. And that's when there was a outpouring of money and support for treatment, was no longer seen as a moral failure or a criminal issue, but one that should be treated with kindness and care. What is really disheartening is that even in this current state, we continue to have rigid methadone policies that largely affect minoritized populations. And for Black people specifically, there's decreased initiation for medication for addiction treatment, and there's a lack of culturally informed care. So why is that the case, and what can we do about that? Just so people understand with language, I use minoritized because people who are even in the majority in the world, people of color, in this country, they are made to feel less than. Even in majority minority communities, they still are made to feel less than. So that's why I use the word minoritized. If we look at different types of substance use disorders, and SUD just means substance use disorders, Black people have poor health outcomes. And I'll just quickly list through it. Even if when comparing alcohol use, white people use alcohol at equal rates or sometimes even greater rates than Black populations. However, Black people have worsening alcohol-related illnesses and negative sequelae. They're more likely to die from cocaine-related overdose compared to white people, more likely to have cannabis use disorder compared to white people, and more likely to suffer from general negative drug consequences. So why is that the case? And what are the conditions that have led to our present day situation? If we're looking at opioid use and fentanyl specifically, which is a synthetic opioid that has led to a drastic increase in death for Black people, we're seeing a drastic increase in terms of the rates of overdose. So on the x-axis is just the year, y-axis is death per 100,000, and you're seeing the red line is fentanyl. This is the main driver of deaths related to Black people, 140.6% amongst African Americans, 118% for Latinx populations. CNN has not covered this. The New York Times has not covered this, but in many states, it's higher than this. But as of 2019, 8 states in the District of Columbia, those are places where the Black opioid-related death rate has outpaced that of the white opioid-related death rate. Still, there are no deliberate attention made to these issues. I'm hoping that this is something that the Biden-Harris administration, we've been in communication, will be very deliberate about addressing in terms of these disparate rates. And then this is a paper, Deborah Furholden, she's a Black woman researcher that published in Addiction, saying that in terms of temporal trends from 1999 to 2018, that Black people outpace opioid-involved overdose rates. A lot of people don't realize that. So thinking about who are you screening when you're thinking about substance use, opiate use, don't overlook Black people in the current opioid crisis. And this is data from a paper that we just submitted with colleagues Friedman and Beletsky, looking at overdose rates amongst Black people in the state of California. And there was a huge increase. The death amongst Black people increased by 20.7% this year compared to 9.3% in 2020. So a lot of that has to do with obviously COVID-19. Here on the x-axis is the year, Y is the age-adjusted rate per 100,000. But the point of this is it's not just opioids, right? So we're looking at methamphetamine, we're looking at cocaine, benzodiazepines, heroin. The yellow line here is deaths amongst Black people. And you can see fentanyl is the main driver I showed you here. But look at the methamphetamine rate. Black people are dying at a higher rates. Methamphetamine, cocaine, they're much higher. With benzodiazepines, white people are dying at higher rates. But here you can see with heroin, it goes back and forth. So again, for us not to be so eclipsed on opioids that we are minimizing the contribution of other substances that are killing Black people. And then if we look at just the risk of having a substance use disorder and having an outcome of COVID-19, this was published just last year. This is an adjusted odds ratio, and the odds ratio is just a measure of association between an exposure and an outcome. In this case, the exposure is having a particular substance use disorder, SUD, and the outcome is having COVID-19. So like if you have an odds ratio of 1, that just means that you're no more likely than controls, people without SUD, to get COVID. But you can see that people with any SUD, substance use disorder, they have an increased rate of COVID just in terms of their physiology, right? And then if you look at opiate use disorder specifically, the odds ratio is 10. What is really disheartening is that if you look at death rates amongst Black COVID-19 patients with SUD, you continue to see a worsening disparity. So here, the blue line is Black people, the orange line is white people, and you can see just having COVID-19 and any SUD, Black people are at a much higher rate of death. And if you have a recent diagnosis of any substance use disorder within the last year, Black people continue to have higher death rates amongst those with SUD. So again, why is this? And I hope to submit to you that it's racism, not race, that accounts for this. Because in a lot of literature and the ways in which people are framing this, it makes it seem like there's something inherently wrong with Black people themselves that are causing these desperate rates. And I hope that you'll be able to see that this has been really intentional and a process of oppression, colonialism, racist drug policy, not addressing the social determinants of health that lead to these poor outcomes. I'm just going to show you one more slide about rates, and then we'll move on in terms of the factors that influence these outcomes. This is a paper that was just published beginning of this year in JAMA, and it was looking at the rates of opioid overdose deaths for people in Philadelphia. And this is important because people always say, Dr. Jordan, why do you have to have it broken down by race? And I say, the patterns are different, right? So here on the x-axis, we're seeing the years from January 2019 until 2020. But the point is, the dark blue line is white people. The yellow line is Black people. And at the height of the opioid epidemic, so last year, right, April, May, June 2020, you see that the rate of death for Black people who were dying from opioid related deaths are much higher. Do you see this? Whereas for white people, it actually decreased. So here we're seeing that there's a pattern in Philadelphia, at least, Black people with opioid overdose during the time of COVID-19 have higher rates of death, whereas white people, their death is decreasing. So what is about the factors, the conditions from a population level that white people have access to in Philadelphia that allow for them to survive with opioid use disorder, whereas Black people are dying? I'm going to outline some of the determinants or factors that I think are causing this pattern. One is the war on drugs, and I'm going to summarize the war on drugs in 3 minutes, guys. Yes, I'm going to do it. Then I'm going to talk about the social determinants of health. Othering or stigma really being social death. I think even the word stigma takes away how stigmatizing and how people are dying. And then the contribution of racism. So those are the things that I want to go through before I talk about my research. So the racist war on drugs in 3 minutes. There's a lot going on in this slide. I'm going to talk you through it. Don't worry, Drew and UCLA. We are in a liberated space together. On the x-axis is years, okay, from 1970 to 2019. On the y-axis is the number of overdose deaths. The peach bar here is just sale or manufacture of substances. The blue line is possession of substances, so possession of drugs. All right, so you can see that most people who are affected by this war on drugs actually are not people that are drug dealers, right? That's the peach line, but people who are actually using substances who are in need in treatment or support. This dark green line is just cutting through and showing you the number of overdose deaths. And at the top are bars to say what was the predominant substance during that time. So in the 70s, heroin, 80s, cocaine, early 2000s, opioids, and now what we're seeing is multi-substance use. Remember I showed you the methamphetamine, the benzos, fentanyl, cocaine, all of that. But what is so interesting is that Nixon, in an attempt to win the presidency, declared war on drugs, and then Reagan came down and doubled down on what that meant. The war on drugs meant that if you were in possession of substances, you were going to be sent to jail as opposed to get treatment. And this has a lifelong legacy that has affected minoritized people in this country. In the 80s, Ronald Reagan doubled down and said, I am going to enact the Anti-Drug Abuse Act, which led to mandatory minimum sentences for people who use drugs, okay? And that's important because that single-handedly led to an overrepresentation of Black and Latinx people in the prison system, still to today, because of these policies. In 2010, the Fair Sentencing Act was introduced to try and make it right because they were seeing how disproportionate it was affecting minoritized communities. But what I will purport, and I hope you will see through reading some of the references that I'll give, is that it did not, even though it decreased the disparity between minoritized populations and white, there still remains to this day, in the year of our Lord 2021, a disparate number of arrests for drug-related crimes if you're minoritized versus white. And all the while these laws were enacted, you see that the number of deaths from drugs continue to rise. So even in the midst of this war on drugs, it did not minimize or flatten this curve. Do you guys understand that? I want to just read this because this is really powerful. This is a John Ehrlichman, who was the top aide to Nixon. He says, was the war on drugs ever really about drugs? And John Ehrlichman said this, and it's quoted, "You want to know what this was really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies. The anti-war left, this was the Vietnam War, and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black. But by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities, which we're seeing the consequences now. So when I talk about strengthen our communities, we have to understand, why were they broken down in the first place? He said, criminalizing them both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes. Hello, Breonna Taylor and the no-knock warrant policy that led to her death. Break up their meetings, what we're seeing with BLM in terms of organizing, and vilify them night after night on the evening news. Hello, George Floyd. Do you understand what I'm saying? This is purposeful, and we cannot understand how to move forward unless we look back. And the African tradition of Sankofa, we have to look back in order to move forward. All right. So what I want you guys to understand this morning in Liberated Space, UCLA and Drew, is this, that the downstream impact of the war on drugs is a life sentence. When people are not given access to fair and equitable substance use treatment, it doesn't just affect them, it affects their entire family and communities. If you have a record, you are limited in terms of your employment. There are places where you cannot access housing. Depending on where you live, it determines if you have access to food. We know that there's food deserts. If you'll be able to successfully engage in the transportation system, if there's one at all. Will you be able to vote, civic participation? We have to understand that what we do and the effects of our policies that are still on the books affect one's ability to integrate or do well in the community. So we can't just say Black people, people of color are not doing well. We have to understand the core. And if we want to accurately intervene on the problem, we have to know that we can't just intervene one-on-one. We have to intervene on a structural level. So that brings me to the social determinants of health. There's many different definitions. I like this one from the World Health Commission. Inequities in health and avoidable health inequalities that arise because of the circumstances in which people grow, live, work, I say pray, play, and age. The conditions in which people live in and die are in turn shaped by political, social, and economic forces. So we have to understand that these are not just things that people were born into by happenstance. This is years of inequitable policy, right? Lack of social mobilization because of the systemic discrediting of many Black leaders, and economic forces. People are not having the access to do well. So when we look at a Black person with substance use disorder, I want us to really think below the surface, have some depth, UCLA and Drew. We need to consider the totality of the social determinants of health that lead to the disparities in SUD. If we focus on this one person, we're never going to get anywhere. That's the point. We have to think about all of the social determinants of health. Another concept that I'd like to introduce into this space, and I only have 30 minutes and I'm going to get through it, guys, is the concept of othering. So to other, if you just look in the Oxford Dictionary, is to view or treat a person or a group of people different or alien to oneself. I purport to you that othering, being left out of the conversation of mainstream America, which is deemed the ideal identity, at least in this country and in many colonized nations in which everyone is compared, when you're left out of the conversation of mainstream America, it affects your health. Othering has resulted in limited focus and funding for addiction researchers that affect Black, Indigenous, and other persons of color. We know this. You don't have to believe me because there have been publications in science and science advances that underscore there is a persistent funding gap for Black researchers. Even when you look at what school they went to, how many publications, how long they've been doing this, still less than 1% of NIH-funded research is for Black people. How can we talk about having equitable treatment if you're not funding the very researchers who are more likely to help the communities? You hear what I'm saying? Y'all today, come on now in this liberated space.
I'm here, we hear it, we hear it.
Thank you. I'm like, we need some feedback. Thank you. Because we have to understand that we can't just serendipitously snap our fingers. We have to have systematic change. This is why now the NIH, and we'll see how serious they are, have set up a whole committee just to fund minoritized researchers. And people say, oh, isn't that racist? No, not indeed. That is called deliberately addressing the problem in order to bring about equitable outcomes. All right, another thing that we can't walk away or leave this is without talking about racism. Shout out to Dr. Jones. I love her. I always show this picture. I was so happy to meet her, and we've become really friendly over the past years. This is her interpretation of race, but really just thinking about racism. Race is a system based on race, right? Ism is a system based on race. So why is racism so lethal? Because it structures opportunities and assigns value based on the social interpretation of how one looks. So then if we get a little bit deeper and we talk about, well, what happens in a racist society? One group of people, usually white, are systematically advantaged and assign more value than those who are othered. And you can put anybody in that other group. Right now, I'm talking about Black people. But that's how Ma'Khia Bryant, a 16-year-old girl, can be killed when Rittenhouse with an AK-47 can be safely arrested. Do you understand? Because inherently, there is more value placed on the white lives, which is why when the opioid crisis hit white communities, there was overwhelming sense of resources and policies put in place so that there can be treatment. Whereas when Black people were dealing with heroin and cocaine use, it was met with criminalization. This is what racism does. Understand that it is a social construct. There is no biological determinism. So if you guys send a paper and I am the reviewer, you better point to racism, not race, as a cause of why this intervention doesn't work. I have published enough op-eds for you guys to understand there is no such thing as Black or Latino people who cannot benefit from a treatment. It is the system of racism that is causing them to not get the full access to the treatment. Do you hear what I'm saying? Okay, so racism results in many harmful consequences. And what is most harmful is that it causes death, which we were able to see in that slide where I showed you in Philadelphia. Black people are dying in the midst of COVID, whereas white people are surviving. Let's talk about the different levels of racism so you understand that this is not just something that you can fix on an individual level. It is structural, right? So institutionalized racism talks about differential access to the goods, services, and opportunities of society based on race. We see that. We talked about housing, education, employment, medical facilities. Who has access to the best medical facilities in UCLA and Drew? I'm just posing that. I'm just putting that out there. All right. Then thinking about personally mediated racism, differential assumptions about the abilities, motives, and intents of others based on race. Some examples, what we're seeing very real is police brutality, physician disrespect. In this liberated space, Drew and UCLA, can somebody take yourselves off mute and tell me what is physician disrespect? Can you describe it? Can you give me an example of how that embodies personally mediated racism. Anybody. And the good thing is I'm a psychiatrist, so I can wait. But tell me, anybody in this liberated space, what does that mean, physician disrespect? Anybody? Don't be afraid. Just, what do you think? And not Dr. Bath. She can't, not Dr. Shervington. Anybody, just take a guess. We need to, if we don't know, because we participated, if we don't even know what it is, then how can we minimize our ability to propagate it?
Could it be when, like, say a patient says they're in X amount of pain and the physician doesn't per se believe them or prescribe them pain medication because they think it could lead to addiction based on like racial discrimination?
Anna, thank you. You are all the way live in this liberated space. Thank you for your contribution. Absolutely correct. So that's an example of physician disrespect. And when it's study in the literature, the most kind of citations that we have is for the under treatment of pain with Black people, but definitely not having access to interventions for Black people with substance use disorders because they believe that they cannot be in pain or that they'll misuse the pain medications because they have a history of substance use. Another example, what we see studied in the emergency room literature, emergency medicine, is looking at how the risks, benefits, and side effect profiles of a particular medication are not adequately explained for Black people as compared to white people. And if there are two people, a Black person and a white person that have the same exact symptoms, and there is a known intervention, in this case was thrombolytic treatment, the Black people are less likely to be recommended the right treatment. This is all examples of physician disrespect or personally mediated racism. The reason why it's important to understand that is we've all been socialized in the system to think that white people are somehow more superior. Whether you're white, Black, half Black and Asian, everybody, we socialize in the system. So we have to be very cognizant of the way in which we unintentionally propagate personally mediated racism and how that lends to inequitable health outcomes. The last level of racism is internalized racism, acceptance by the stigmatized races of negative messages about their own abilities and intrinsic worth. In terms of addiction specifically, why this matters is because people already feel defeated before they even engage in substance use treatment, right? So if you feel like your life is inherently worthless, or that there's no hope, or that there's no environment that you can go back to that actually respects your humanity, what's the point of initiating substance use treatment anyway? So that's really important to be able to figure out how to integrate that into your treatment planning. I wanted to include this because this is from, again, the World Health Organization, but just to think more globally, how people think about addiction. They have this MNS classification, which stands for mental health, neurologic, and substance use disorders. And they put it together because they feel that these orders are inextricably linked. And so there's a real high disease burden in terms of morbidity and mortality related to the stigmatizing nature of MNS, mental health, neurologic, and substance use disorders. And I have been thinking more about how can we be more purposeful as mental health providers to think about substance use in its totality as opposed to just focusing on the substance use itself, without really acknowledging neurologic disorders and mental health disorders that often track with substance use disorders, because I think that will be a way for us to improve mental health outcomes. Another thing I just want you to see here in this graph is the percentage of total disease burden. So high income countries is somewhere like the United States or Canada. You see that even though we spend in the United States the most money on healthcare, we have the highest total disease burden related to these illnesses. So what we're doing is not working. We have to switch. We can't keep doing the same thing and thinking that we're going to have different results. That's the definition of insanity, right? So now, what can be done? Drew and UCLA, I did not come here to depress you. This is the work that I do. I am not a depressed person. I feel actually motivated because there's so many ways in which you can intervene. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has, right? So one of the things that we're going to have to do, shout out to Helena Hansen in her paper in 2014 with Jonathan Metzl in terms of structural competence. We have to transition from cultural competence to structural competence. And here, I'm not saying to totally erase someone's cultural identity and not be culturally humble. But what I am saying is that we have to be of two minds. We have to hold their cultural identity, but also focus on all of those outside factors that are going to determine how someone actually does with substance use treatment. So here you see, this is the Black, white patient, whatever, the Black provider, the white patient. A lot of times with cultural humility, we just focus on this diet, right? You see in this graphic here. But what about the media? What about mass incarceration? What about school and housing segregation? How can we incorporate all of that into our treatment planning? And one of the ways that we do that at Yale in my clinic for people who rotate with Dr. Jordan is we integrate into the treatment planning the structural vulnerability tool. And so my number one problem will be cocaine use disorder. I see a lot about that. But number two is housing instability. Number three is food insecurity. Number four is experiencing homelessness. All right. So these are the things that we need to think more broadly. Doesn't mean that I have to solve those problems, but I need to practice structural competency to engage with the necessary experts to address that. Another thing is we have to be very careful with our language. We as health professionals cannot use things like abuse. I know SAMHSA still has abuse in their language. I know NIDA still has abuse in their title, but we have to say use, unhealthy use, harmful use, because that shapes the way people see themselves, but also in terms of their treatment trajectory. We don't want to say things like an addict or a drug user or an addicted baby. We want to use terms that are affirming of what is happening to the person. So we say they returned to use, or they were having a heavy drinking episode, tobacco use disorder treatment, baby experienced substance withdrawal as opposed to addicted baby. This all matters. When I get a consult in the hospital and they say, oh, can you come consult on this mom who's been using heroin, her baby's addicted. I'm like, oh no, you must be mistaken. I don't work with addicted babies. Do you mean baby experiencing substance withdrawal? So I really try and model so people understand. And there goes the really nice citation for that. Also, in terms of just providers, you don't have to be an addictionologist to realize that there are other treatment modalities, evidence-based treatment modalities beyond Alcoholics Anonymous. That works for some people, but understanding that that was developed by two white men that were not thinking about a minoritized perspective. So that can't be the only recommendation that you give for patients who use substances. Not that some people cannot have utility, but if it doesn't work, allow them to have access to other things. And these are just a few. All right. The last thing that I'm going to go over in the last 10 minutes is some of the work that we're doing. And I encourage you all, I always say, read the work. Why am I publishing otherwise? Just read the papers. But I want to talk to you guys about it to walk you through. It is a type of research called community-based participatory research. And I love this fist, power to the people. Right before I gave this talk, I'm on my friend's boat and he gave me a fist, like power to the people, Ayana. He wanted me to do well on the talk. The point is that the research in which I engage in is all about partnership. It equitably involves community members, people who live in the communities in which I'm trying to serve, key stakeholders. In this particular instance, is Black people with substance use disorders. other types of researchers, addiction researchers, epidemiology researchers. All of them are engaged in all aspects of the research process, from the very beginning of what question do we need to ask to the end in terms of analysis. And it definitely takes much longer for sure, but I do believe that this is one modality that can really ask the necessary questions in order to bring liberation to folks. So I'm going to talk about two projects. One is both are Black church-based projects, but one is called Imani Breakthrough. Imani means faith in Swahili. That was given to us by the community because they wanted to signal that this is something that is combining traditional substance use treatment with spiritual treatment. This is Sherelle Bellamy. She's an amazing woman in recovery. Talk about challenging the status quo. She is someone that used cocaine and heroin, and now she is soon to be a professor at Yale. So she is the co-investigator, and we have worked together on Imani Breakthrough for the last 3 years. So what is Imani Breakthrough? It takes place over 6 months. We're now in 8 churches throughout the state of Connecticut. We have treated over 1,000 people. There's 2 parts to it. The first part is a group component. All of this is done in a church setting where we focus on the Citizens Project that was developed at Yale, and it has been shown for people with serious mental illness, if they engage in the Citizens Project over 12 weeks, they're able to decrease their substance use without any medication, guys. So what are the substances, or what are the key elements of the Citizens Project? The 5 R's: roles, responsibilities, relationships, resources, and rights necessary that people must know and learn about in order to initiate recovery. So remember, I had that picture of Maslow's hierarchy talking about needs. If you don't address what are the roles people need to play in society, what are their responsibilities, what relationships are needed, what are their rights in terms of being involved in civic participation, all of these things have to be discussed if we're really thinking about maintaining a recovery-oriented community. Then we provide, during those safe 12 weeks while they're in group, they come to the church once a week and go through the classes, wrap around support and coaching. So they identify in the 8 dimensions of wellness, which is SAMHSA's way of thinking about the social determinants of health, what are the gaps in the social determinants of health that they need to address? And they're assigned a recovery coach from the church, someone that has lived experience, and they work on those gaps in their 8 dimensions of wellness. So if they need to find housing, or if they need to go back and get their GED, we have some people who are functionally illiterate and they want to learn how to read. These are some of the gaps that they will identify, and the recovery coach will help them. The next part of Imani, after they get through that, is the next step component. So once they get finished through those first 12 weeks of doing the Citizens Project, then we focus on 10 weeks of mutual support. And all the while during Imani, if they want to engage in traditional substance use treatment, not only do we refer them to substance use treatment, but they have a partner who goes along with them to make sure that they feel safe. Because I'm going to tell you, a lot of times you walk into these spaces, and I am a grown woman who is very much intact with her humanity, and I still walk into places, they don't say hello to me. They don't even look up. Everything on the wall is white people. There's nothing that's reflecting of my identity. So it's very hard for people who are living at the margins of society to sustain substance use treatment without seeing their reflection. So I just want you guys to see that in Imani, we do things a little bit different. Our population of interest is Black and Latinx people who use opioids and other drugs. But the key components are not necessarily buprenorphine, are not necessarily methadone or nicotine replacement. We refer them to all of that, but we focus on the social determinants of health, or the 8 dimensions of wellness. We allow them to be free in their expression of spirituality. We give them peer support, right? We also talk about the 5 R's that they need to initiate recovery. And then in terms of outcomes, historically, people just want to focus on, did you stop using substances or not? I always tell you, I don't care if you stop using substances. I genuinely don't care. They said, Dr. Jordan, you don't care. I don't care. How are you being in terms of a father, a mother, a sister, a brother, your social supports? Are you able to pay taxes? Are you able to do something that you love, engage in creative experiences? This is what I care about. That is recovery. Because I need to get NIH funds, of course I have to put in urine toxicology because they're not quite there yet. But these are the primary outcomes. I'm going to skip over some of the quotes, but there's just wonderful quotes of some of the people that were involved in Imani. And we have graduation. The reason why we have graduation is because when we were developing the project, people say, you know, I've never got a certificate. I've never been honored in front of people. So we have a big party. Well, this was pre-Rona, guys. Now everything's virtual, but we still celebrate on Zoom. And anyway, it's just a way to acknowledge their participation over the last 6 months and have an opportunity for them to invite people who have not seen them in a positive way, affirm and bear witness to what they're able to do. All right, I'm just showing you here that this is some data from Imani. This is from the 808 because we got rid of the first cohort. But basically, in the light gray is baseline, the dark gray is after week 12. But in terms of their change in their scores and the 8 dimensions of wellness, their physical, intellectual, etc. environments, that after participating in the first 12 weeks of Imani, they had an improvement in the 8 dimensions of wellness across every single factor, every single dimension. They had an improvement. And then looking at terms of the citizenship subscale, so those are the rights, roles, responsibilities, all those things that you need to in order to initiate and sustain recovery, that they were able to have an increase in stewardship, civil rights, personal choice, all these things. So what are we doing now? We are submitting a grant. It's due May 20th to look at how can we not refer people out to traditional settings of care in Imani, but how can we provide MAT in the church setting itself to eliminate major barriers to the uptake of this life-saving treatment? So what people said is, you know, Dr. Jordan and Dr. Bellamy, we love Imani, but we don't want to have to be referred out. Is there a way that we can see someone? And we thought about this. What can we do? Should we do a van? Should we do this? And what we're proposing is to have folks come into the church as they usually would for Imani, but to have a psychiatrist that's reflective of the community. Thankfully, we have 2 Black psychiatrists, 2 Black Latinx psychiatrists who are actually going to come in via telehealth to the church and provide MAT. So that's the grant that we're working on now that we're going to submit. And what is really nice is that they'll be able to engage in medication for addiction treatment, like in a safe environment where they don't have to worry about transportation or anything like that since they're already at the church. And then we also can expand our harm reduction services. We already give out Narcan and things like that, but we want to scale up so that we can have access to safe syringes and all of these things. So that's kind of the next step for that. In the last 5 minutes, and I promise I'm going to stop, I want to talk about the Black Church Project that was just funded through R01 for 5 years. So thank God that I am part of the less than 1% of Black researchers that got an R01 grant from the NIH. But isn't that terrible? So how can we make sure that more people who look like me are able to get their work funded? I'm very excited about this. Here it's me with the pastor of the church where we did the pilot project, Reverend Streets. And this is the mayor of New Haven, because it's a community approach. I said, everybody has to be involved. The mayor, what resources are you going to give us so this is successful? These are the research assistants. You see that they're Black because this project focuses on Black people. These are people who have community informed experience. They are experts. They're in recovery. Kim Guy is in recovery from cocaine use disorder. And Richard Ewins is in recovery from heroin and cocaine use disorder. And they are the RAs that are part of this project. I'm just showing you the pilot research, the data here. All of the demographics are Black, 40 folks. We have scaled up for the RCT, we're doing 200 people, but this is the pilot. Only 8% were employed. Most people were living alone or had never been married. So thinking about how isolating it is for them. And half of the sample met criteria for severe substance use disorder, because one of the things that people critiqued me and said, you can't have people who are severely affected by substance use come to the church. And I'm like, said who? What are you talking about? You don't even know. So we were able to show that. So just so you know, what is the actual process when they come into the church? First is they're greeted by what's called church-based health advisors, all people, some who have lived experience in substance use, some who don't, who work at the church. They come in, and the first thing when people hit the door is they say, we are so happy you're here. We're so glad, you know, it's just they're acknowledging their presence. Then we go through the things that we need to, collecting urine, alcohol, breathalyzers, things like that. We eat together. Then they go into the CHAs, whatever the spiritual session is. They open up with affirmations. If people want to do testimony, which is when you get up and just say, you know, what you're thankful for that day. They listen to a song, and all of this is really highlighting whatever the skill is that they're learning from the computer-based treatment for cognitive behavioral therapy. So the actual intervention itself is the CBT for CBT that Dr. Bath introduced earlier, that was developed by my mentor, Kathy Carroll, that has been shown to decrease a host of substances, all by gaining skills on the computer, right? So they undergo the modules, computer-based training for cognitive behavioral therapy, and then they actually do the workbook in the church itself, because the way that CBT was designed is that you take the workbook home, but a lot of my folks don't have homes. So they do it in the church and then they're done, all right? But they did that for 8 weeks. I just want to show you here, I'm going to skip to this, that just in 8 weeks that we were able to get a significant reduction in cocaine and cannabis, guys, without any other treatment. So even though that was not even the outcome for this study, we were just trying to show that we could bring people with substance use disorder who are Black into the church and that they would be acceptable of it. But we were able to show in just a short amount of time that we were able to reduce substance use. Another thing that we were able to do that helped us get the R is show how many people completed the study. Only one person dropped out of the study. So they really liked it. They were very satisfied on a scale from 0 to 5, 4.5 in terms of how satisfied were you with the treatment you received. So that's pretty awesome, guys. I mean, I was really happy by this. Guys, you just have to trust me. The main takeaways, because I want to get to some Q&A in this Liberated Space, is that it worked. People felt validated. They felt like, you know, their needs were being met. We were able to bring an evidence-based modality, take urines, breathalyzers, all that, do that in the church. Adherence was excellent. And among those entering treatment that had a positive cocaine or cannabis, they were able to see significant reduction in their use over time. So I will say to you all, the time is now to take action. Not everybody has to be a community engaged researcher like Dr. Jordan, but what can you do in your own backyard to systematically fight against racist, oppressive forces? I saw this on Facebook. George Floyd isn't a wake-up call. The same alarm has been ringing since 1619. Y'all just kept hitting snooze. I'm glad America has discovered racism last year, but the bottom line is that it's been affecting folks who look like me for centuries. And how can you think in your own practice about ways to be more anti-racist and promote recovery from whatever that means for you? For me, it's taking care of people with addiction, but for you, it might be for serious mental illness or PTSD, whatever it is. You have to be thoughtful. You can't just randomly keep doing the same thing when we see what the results are. Then thinking about, what does it mean to be anti-racist? Like, it's not just cool, like I'm anti-racist. What does that mean? It is an action. So this is a spectrum in terms of going from the fear zone to the growth zone. And the fear zone is like, I strive to be comfortable. This is a safe space. No, there's no such thing. When I have to talk to my nephew about what it means to go outside with a hoodie, there's no such thing as safety, right? So move along that paradigm to a growth stone. Think about, sit with your discomfort. What do I do with this? How can I yield my power to help those who are marginalized? How can I educate my peers? How can I educate myself about racism and how I am unintentionally or intentionally propagating harm? These are the things that you need to move away from. I love this. Now that I have my own lab, I love this really like worksheet, and it talks about what is your assessment of your treatment or your research culture. All of these things on the left are really derived from a white supremacist framework. And all what I mean by that, because people are like, oh, Dr. Jordan's using white supremacy in her grand rounds talk. It's like, yes, y'all. All I mean by that is just cultural ideals and norms that are consistent with white people being superior than those of others. So these are some examples of white supremacist culture and how it shows up in treatment and research culture, and then ways that you're able to counteract that. So this is really awesome. You know, sense of urgency. We have to get this done. We have to get it done now. We need an EDI committee and all this other stuff. But it's like, guys, stop. I know you just discovered racism, but this has been going on for years. So let's slow it down and think about ways that we can involve people who are most adversely affected and pay them in the process to bring about equitable outcomes. And then I'll say, and then I promise I'll stop. I keep saying I'm going to stop, but I just have so much to share today in this liberated space, is thinking about what are the necessary factors to have an anti-racist approach. How do you operationalize that? You have to have voices from Black communities. In my case, in your case, it might be AAPI, it might be Latinx, whoever. Voices that are most affected have to be involved in the narrative. And if they're not, then you're not anti-racist anything, right? So that is just the truth. Leaders must be cultivated. Not everyone has had access to the same education as you have. That is a privilege. To be able to sit and think about ideas is a privilege. To be able to think about your delivery of talks and how you write is a privilege. Not everybody has access to it. So you have to invest in leadership. It has to be something that is deliberate. How can I bring folks from the community or people who are marginalized and develop them into leaders? How can I help them in terms of policy development, implementation of the work and their ideas that they have? And then we have to be very systematic about removing unnecessary barriers to health. This is something that I feel strongly about. And another project that I even talk about is reforming access to methadone. Why is it that we require people to come in 6 days a week to get a medication that is life-saving? Why does it take 2 years before they can even get 1 month of their take-home dose of methadone? That is ridiculous. We wouldn't tolerate that for any other illness. So why are we tolerating that for substance use? That's an example of a barrier that has to go. And finally, I'll conclude with this. Racial justice or racial equity goes beyond just anti-racism. It's not just the absence of discrimination and equities, but the presence of deliberate systems and supports to achieve and sustain racial equity through proactive and preventative measures. So UCLA and Drew, we have to understand how the war on drugs, understand your history. How has that contributed to the present day race disparities? Assess for those, the trifecta. Remember that we talked about the mental health and neurologic disorders that can come with people who have substance use disorders. Practice structural competency when possible. Really link up to people who are doing social work, people who are working in the legal space to really improve health outcomes. And consider how minoritized identities, things like race, gender, multiple medical comorbidities, impact how you optimize care. That is what culturally informed care means. I'd like to close by acknowledging all the people that work with me in my lab. I'd like to acknowledge my fur baby, Wangari. I got her, she's a Rona puppy. I'm an auntie, so all of my babies here, these are all of my nieces and nephews. Let me go back. I love them. Okay, so they know this is Ayana. She lives in Sierra Leone. She was born the time when I first started doing research, and I just love her. Everybody, these are the reasons why I do what I do. And then I always say my mentor, Kathy Carroll, just died last year, December, unexpectedly. And I just know her spirit is watching is over me. She always says, Ayana, are you sure we can bring CBT for CBT? She invented that to the Black church. I'm like, watch me, Kathy, watch me. So I just thank her and honor her legacy. And I'll stop. Any questions, concerns? Thank you, guys.